You are all very welcome this afternoon to our Sláintecare webinar. I'm Gráinne Healy and I am delighted that you've joined us for today's session. This Sláintecare webinar is the second in a new series of webinars, and we are delighted to be delivering this session in partnership with the HSE. As always, we are very happy to take questions or comments from you, the viewers. Just use the chat function and I will convey your remarks to the panel of guests with us this afternoon. Sláintecare is about the right care in the right place at the right time by the right team. In Ireland, we have a growing and ageing population, and while living longer is good news, increasing life expectancy creates its own pressures in terms of the increasing prevalence of chronic disease. Over 1.3 million people in Ireland are living with at least one of four major chronic diseases, namely cardiovascular disease, COPD, asthma, and diabetes. We need to respond to the changing needs of service users by changing how we deliver healthcare. Our webinar today is going to focus on the role of advanced nurse and midwifery practitioners and how their role is having an impact on the key challenges facing the health service. We'll hear about how the advanced practitioners are managing long-term conditions, improving patient access to services, and reducing waiting times. During the webinar, we will also have an opportunity to hear from patients, to hear the firsthand from them the benefits that they are experiencing. I think it's important to remember that while today our focus is on the role of advanced nurse and midwifery practitioners, we know that there are many healthcare professionals, managers and staff right across all the various disciplines, such as the health and social care professionals, clinicians, ambulance service, HR, finance and many others that are working together to improve the health and well-being of the people of Ireland. So, while today we're talking about advanced nurse and midwifery practitioners, we will be coming back to focus on other staff groups and their contributions in future webinars. Before we begin our conversations with those involved in developing and delivering advanced nursing and midwifery practitioner services, I am really delighted to be joined this afternoon by Kelly Mofflin. Kelly is the Deputy Chief Nursing Officer at the Department of Health, and Kelly is going to open our proceedings with a statement to us this afternoon. You're very welcome, Kelly. Going to unmute yourself there. Please go ahead and make your statement. You're welcome.
Thank you, Gráinne. So good afternoon and welcome to everyone joining today's webinar on the role of advanced nursing and midwifery practitioners in implementing the Sláintecare Health Reform Programme. My name is Kelly Mofflin and I work in the Nursing and Midwifery Policy Unit in the Chief Nursing Office in the Department of Health. Firstly, I'd like to thank Rosaline Harlan for asking the CNO office to join the webinar today. And I'd also like to take the opportunity to thank our advanced practitioners, Adele, Maurice, and Kira, who will be sharing their work with us in today's webinar. I look forward to hearing about the work they are doing and to see how it makes a difference for patients in our healthcare system. Equally, I'd like to thank Brian and Una, who will be sharing some of their experiences of care provision by advanced practitioners. Patients are at the centre of Sláintecare and at the heart of everything we do in nursing and midwifery, no matter what role we may be working in, even policy in the Chief Nursing Office. Hearing directly from patients about their experiences of the impact of advanced practice roles in their lives will certainly be an opportunity for us to reflect on the valuable contributions advanced practice can make to the lives of patients and their families, friends, and carers. Nurses and midwives have a unique role in patient care. It's a role that is very privileged, and our mission is to continuously improve care and experiences for patients and their families, and that's what helps to unite us as a profession. Nurses and midwives have a special opportunity to build therapeutic relationships with patients and families, and we've heard from patients the value they place on continuity of care, which is something advanced practitioners are able to raise to a new level through their ability to deliver full episodes of care for patients and their families. The model of care provided by nurses and midwives in specialist and advanced practice roles goes a long way towards ensuring that care is delivered by the right person at the right time and in the right place, which is Sláintecare in action. When patients can be seen at the right time and provided with the right treatment or intervention and then discharged appropriately, we have seen this have positive outcomes for patients and organizations. Expansion into community settings is going to continue to grow, where there are developments in the number of services being provided, for example, to older people by nurses in specialist and advanced practice roles. And we can already see the positive impacts for some of these vulnerable cohorts of our population who may otherwise have had to present at emergency departments. However, we do know there will be further pressures in the coming years due to increasing demands for services that are driven by a population that is growing by 60,000 per year. In 10 years' time, there will be more people aged over 65 than under 14. More people means more demand. And as well as needing the right infrastructure, such as people, buildings, and e-health, to deliver the right services, we also need to rethink how we deliver these services, placing a greater emphasis on prevention and population health initiatives in order to support people to live independently in their own community for as long as possible. So, by scaling up the critical mass of advanced practitioners, we can progress the Sláintecare principles and objectives by supporting the delivery of integrated care services across hospital and the community, whilst improving access to care and providing care closer to home and caring for people in the community. The benefits of specialist and advanced nursing and midwifery practitioner roles will ideally position nursing and midwifery to lead and be key decision makers in healthcare reform requirements under Sláintecare. I have mentioned earlier that nurses and midwives have a unique role in patient care, and that is a role that is very privileged. The mission for us is to continuously improve care and experiences for patients and families. Today's webinar will be a great opportunity for all of us to hear and see some of the work that advanced practitioners are doing in support of the Sláintecare reform of our healthcare system. Nurses and midwives are essential in implementing Sláintecare, and we can see where expanding specialist and advanced practice makes a real impact on patient care. This evidence and the evidence of advanced and specialist roles addressing some of the key challenges in the health service are so important for advancing our professions. We have seen advanced and specialist roles have a positive impact on waiting lists, access to services, improved patient care, and overall patient outcomes. And some examples include patients have been seen and treated on the same day in gynae and women's health clinics, reductions in patient waiting lists for services such as diabetes, leg ulcers, and urology, just for an example, and the reduced need for hospitalization and mental health services, and these are just to name a few. We've also heard from patients that following care by advanced practitioners, they felt better informed and able to self-manage their conditions and felt they had been treated with dignity, empathy, professionalism, and kindness. And it is these qualitative impacts that are just as important as the quantitative outcomes that as nurses and midwives, we need to be cognizant of in all we do and at all levels, including policy. So now I will hand back to Gráinne.
Thank you very much for that, Kelly. And Kelly will be rejoining us later for the panel discussion, but that was a super overview, I think, of the programme today. And we're now going to dig a little bit deeper, I think, into what Kelly has described in her introductory remarks. I'd like to move now to hear directly from some of the advanced nurse and midwifery practitioners, which Kelly has mentioned to you. I'm delighted, firstly this afternoon, to be joined by Adele, Carey. Adele is a registered nurse prescriber and a registered advanced nurse practitioner in older adult care with a specialist focus on dementia. And she's developed the ANP Felican Bone Nursing Service. I spoke to Adele earlier. So I'm delighted to be joined this afternoon by Adele, Carey, and as you know, our theme this afternoon is looking at advanced nurse practitioners. Adele is an advanced nurse practitioner for older persons and specifically in the area of dementia. Adele, you are very welcome to us. Can you start by telling me, how did you become an advanced nurse practitioner?
Hi, Grania, and thanks for the invite. I trained as a general nurse and I would have moved into older persons area in 2003. At that time, I had a huge interest in, I suppose, cognition and behaviour. So I sourced out a course in that in University College Cork, which led me on to become a nurse specialist within the area of that. During this time, I would have done a lot of research and developed a lot of tools. And later in that role, I was about 10 years, I suppose, I developed a comprehensive care pack. At that time, I really felt that my work in that area was done. I had progressed it to the level that I could. So I approached my director of nursing, Fiona Cleary, and Dr. Seamus O'Dea to see was there scope to support me in advancing to advanced practice. And they agreed with that, and they would have linked me in with the Nursing and Midwifery Practice Development Unit. Sheila Cahalan. I went on then to do my advanced practice training and in 2017. And at the end of that year, Sheila contacted me about the Department of Health demonstrator site project funding. So there was a business case for this initiative, which I completed with the help of my director and Sheila. And I submitted that, and I was delighted to have received a candidate post in that. So I continued with my training. I registered as a nurse prescriber in 2018 and as an AMP in 2019.
Right. So all of this leads us to this wonderful initiative that you have been the driver of, Felican Bone Nursing Service. First of all, for the non-Gaelgoers among us, what is a Felican Bone?
So Felican Bone is white butterfly. And for this service, it represents hope and transformation. Hope in the sense that life is not over at point of diagnosis, as lots of people think, and transformation that merely they adapt to things they did before in a different way as their need changes. So Felican Bone is a multi-element pathway structured nursing service that I developed. My background was behaviour, and that was something I was very sure I wanted to bring in the advanced practice role. I got the opportunity, I suppose, to work in the community, and that's where I potentially started to get feedback from patients and their care partners. And I call them patients because I put out a poll to them: if I'm talking about you outside of the service, what would you like to be called? Patient, service user, or client?
And some people hate client. They hate that. Yeah.
So patient was the word. So that is the term, I suppose, I will use throughout.
Yeah. And what was the problem that you were trying to solve in developing this service?
I suppose I wanted to provide a service that looked at care and support for the person that was living with dementia and their family. It needed to include the family. But I wanted it to be, I suppose, from point of diagnosis and throughout the journey. We talk about person-centered care and the concept of that, but we need to deliver on that. And in order, I suppose, to deliver on that, we need consistency and continuity. So the way that I developed the service was that I have 5 different pathways with many care elements in them. But say, for instance, if a person is referred into one pathway and they come into me for assessment and, they're too anxious or there's something going on that can't, continue on that pathway, I have the ability, I suppose, which is unique, that I can move them to another pathway, treat the anxiety, and then move them back. So I'm looking at them throughout their whole journey. So they're familiar with me, and that reduces anxiety in both the patient and the family care partner.
Very good. And of course, that reduction of anxiety is a huge element in the care for both the patient, but also for the carer, I think. And those 2 elements seem to me to be hugely beneficial, and you've really focused on them. The benefits then, the benefits of being part of this service that you've developed, both for the dementia patient and for the carer. What are the key benefits, do you think? What have you seen?
I suppose looking back at the overall service, the key benefits, one in particular would be cross-service innovation that I completed, which is a psychotherapeutic piece to look at people at point of diagnosis and to help and support them to process this diagnosis so that they're able to adapt and adjust to it and live their life well and remain in the community. So it was about, aging in place and allowing them to function as we all do in the community with the particular supports. So I secured that program. So that's a huge benefit because it's something that's not looked at across Ireland. So it is unique.
Very good. And the setting, I think you've taken it out of the kind of acute hospital setting where many people would have found themselves. You've taken it out of that setting into a community setting. I would imagine that reduces anxiety as well for people.
Oh, absolutely. I mean, patients walking in the door, first clinic appointment, they don't need to speak to me. They're screaming anxiety. Yeah. And then to see them come in the next appointment, you can see all that going down. It's a much, warmer, homely environment. And it's where they should be because they're living at home in the community. So their services need to be in the community. And while there is great work going on in the community, it doesn't capture the person living with dementia because they're physically well. So yes. This is why I wanted to provide a service, from beginning and throughout the journey.
So what kind of outcomes are you seeing and what kind of feedback are you getting from the patients and their families?
I suppose the outcomes have blown me away. In the first 3 quarters of this year, so January to September, I've had 173 referrals in.
Wow.
I've completed 10 live-down programs. So this is the psychotherapeutic at point of diagnosis. For the patients themselves, I've seen confidence up by 90%, mood, I think it's around 53%, quality of life around 57%, anxiety down 44%, and cognition improved 12%. Now, we all know dementia is a progressive illness.
Yes.
So cognition hasn't improved, but with the anxiety reduced, the memory has cleared. And that allows them to function better in the community.
Yeah.
For care partners, I use international tools. So the Zared care burden was down 40% and quality of life up. So that's huge for them as well.
Absolutely.
And if we're to sustain aging in place, providing the right care at the right time in the right place, we need to support the care partners because they are the informal caregivers and at the forefront of this care.
Exactly. And it's that whole family approach as well, which I think is beautiful about this initiative. So Adele, from your point of view, what's next? And is it possible that you could be replicated in every county up and down the country?
Well, I don't know now about me being replicated, but look, lots of things have happened. I was recently at the Irish Gerontological Society and was awarded the President's Prize for a poster.
Congratulations.
Thank you, for a poster presentation of my service, which was great because now things are moving. I've met with my senior management who have linked me into the project management office. They are working to support me to map my pathways. I've already met with the National Dementia Office and the Nursing and Midwifery Practice Development, and they are remaining in contact until my work with the project management is done. And we will meet again, and the overall vision is to replicate nationally. And I think that piece is crucial, that everyone across Ireland gets this service. And I think nurses, in particular advanced nurse practitioners, are optimally placed with the skill set to deliver on this service.
Well, Adele, it's great work, as you know, with our aging population and with the numbers of people presenting with dementia. This really seems to me to be such a welcome development of service. So well done you. Congratulations again. And I do hope to see your service replicated throughout the country, building on your innovative work. Thank you so much, Adele, for joining us this afternoon.
Thank you.
So that's Adele. Let's move now to hear from Brian and Una, who have been getting supports from Adele and the Felican nursing service. So we are now joined by Brian Murray and Una Crawford, who many of you will, of course, recognise from your TV screens. They play husband and wife in First City, and many of you may not know this, they are a real live couple, also in real life, or for real, as my grandson talks about life. Brian recently revealed that he was diagnosed with Alzheimer's disease 3 years ago. And Brian and Una are attending the Felican service, which was set up by advanced nurse practitioner Adele Carey, with whom we've already spoken this afternoon. So Brian and Una, you are very welcome to our webinar this afternoon.
Thanks very much.
Nice to be here.
So today we're looking at the role of the advanced nursing and midwife practitioners and how they're contributing to the reform of the health service and helping to achieve better outcomes for patients. Could you start by telling us, how did you hear about this Felican service, and how was the service different to other services you'd engaged with since Brian's diagnosis?
Well, Brian was attending St. James's Hospital, the memory clinic, and he had already done the SMART course in there, and he had said he would be up to do any course that he could, because he wants to fight this as much as possible.
Absolutely.
So he was well prepared for it. And they told us that there was this course going on. Brian had been accepted the LiveDem course in Cherry Orchard Hospital, and would he like to do it? And he said absolutely, he would be delighted to do it. And that's how we first heard about it.
And how has it been?
It has been fantastic. The difference, I suppose, when we were attending St. James's Hospital, just to speak of that first of all, it was very much a hospital environment. And we would go in, there'd be long queues, hospital corridors, people all seemed to be rushing somewhere. You felt people were under pressure and in a hurry, no fault of their own. But Brian and most of the people with dementia would be well, and this would be something that would be very disconcerting to them, because we're in a hospital environment and there's nothing wrong with them. Except for the memory.
Yes.
So that was one of the things. And they also spoke only to the person with dementia, which for me as a supporter, and I know speaking to other supporters, that was a very difficult thing to contend with, because they just spoke to Brian, and we would remain seated there saying nothing, yet we would be the people who lived with them most of the time. Or I don't mean lived with them most of the time, I mean lived with them. But so not everybody lives with the person with dementia, but you know what I mean. But so it was very difficult in the hospital. So then when we turned up in Adele's, as we will call it, Felican, it was like a breath of fresh air. We arrived in, it was a much smaller place. There was no queues. We were the only people there. We went in, we were greeted by this smiling face who welcomed us. And it was just, you felt at home, you felt relaxed and at ease, which was not the situation where we're in a hospital.
And how do you think the Smiling Adele service, as you put it, how do you think it has impacted on you? What benefits have you felt from it for Brian and indeed for yourself? Well,
Brian, we were talking about it earlier, and because he was afraid he'd forget what he wanted to say, he wrote it down.
Perfect. So man after my own heart, organised. Good man, Brian.
So he's going to read it for you.
Thank you.
Well, Adele, you know, not to speak too much, but Adele and Felican have been a really great support for me and the other people that she looks after. I've been really encouraged by her for a number of things. I now do word searches every single day on a daily basis. I go walking with my darling dog Bob most every day. If Adele suggests something, it's for my own good, I always think. Between the support of Adele and Una Crawford O'Brien, I feel I'm actually a very lucky man, Alzheimer's or not. I look forward to my monthly get-together at the Memory Lounge, which I think the Memory Lounge sounds like a lounge bar on a cruise ship. Unfortunately, it isn't. But anyway, being with like-minded sufferers is relaxing and energizing at the same time. I'm looking forward to our next meeting, which is just before Christmas. Adele is a genius, and thank goodness for her.
That's lovely. Thank you so much. And for you, Una, the difference that these meetings have made for you in your caring role?
It's been a great benefit to both of us. And Adele and Felican run a support group every fortnight. And like Brian said, to be with like-minded people, to be able to converse, to listen to their problems, to be able to say if I have a concern is just incredible. Sharing experiences and listening to others. It's been a huge support for the supporters, and that's really important as well. Adele, yeah.
I actually think that this whole thing, as bad as it is, that you learn so much by actually being where we have been and where we're probably going to go. And the meeting, what Adele has done and the grouping as we have it, I actually look forward to going to it now. It lifts me up. It lifts me up. And it gives me a sense back of my own self. And it's worth anything, really.
She's always on the end of the phone as well if you have any problems. And if she doesn't have the information you're looking for, she'll go off and she'll seek it out, and she'll come back and she'll get it. She also gave us information and pointed us in the direction of websites. She showed us firsthand things that are so important now in our everyday life, like the memory clock, or the whiteboard that we have beside the bed that Brian looks at every morning.
Every morning, it's the first thing. Oh, there we go. Oh, that's what we're doing today. Thank goodness for that.
That's all. That has been invaluable. What was I going? I made a few notes as well. Oh yeah, she also encouraged us to join a memory choir, the two of us, and we go to that every Monday morning. And there's about 6 of her group in that, so the 6 and then the 6 partners, and we come out of it every Monday morning totally uplifted.
Oh, absolutely.
And it's with her encouragement that we went and that we did it. And we know we're so lucky to be in Dublin. I mean, we were talking about this earlier. I wouldn't want to be in the country where there isn't as much support as we have. And if you could clone her, I said this before, if you could clone her, we need one in every county.
Very good. Look,
100%.
Thank you both so much.
Can I say just one last thing? Felican, it's like being a member of a family, not an organization. And that is really very important to the two of us.
Well said. Well said. Listen, wishing you both health and happiness, and have a lovely Christmas together, and hope all goes well for you in the future. Thank you so much for joining us this afternoon.
Thanks, Claudia.
Thanks very much. Thank you.
Well, isn't that an amazing testimonial? And well done to Adele on providing this person-centered service and listening to and hearing what the patient needs and being able to respond. Thank you, Adele, and thank you in particular to Brian and Una for their insights into the service. That was very special. I'm now joined by our next speaker. I'm delighted to introduce Maurice Healy. Maurice is a registered advanced nurse practitioner specialising in intellectual disability. He currently works for the Brothers of Charity covering the Galway region. On a daily basis, Maurice utilises behavioural assessment to direct the use of practical strategies and supports grounded in the model of positive behavioural support to support individuals and their families. Maurice, you're very welcome.
For me, Margaret Granion, thank you.
Can you start, Maurice, by telling me, how did you become an advanced nurse practitioner?
I suppose it goes back a bit, and I'm probably showing my age now, that I started in intellectual disability services in 1985, which is probably a lot longer than some of the people listening have been on the planet. I'm 37 years this year. So I started, and when I started there, I found myself drawn to the area of behaviours of challenge and the individuals, and trying to figure out why people might engage in these kind of behaviours. I trained as a nurse in Lisnagrey in County Limerick, and then I went to work for the Brothers of Charity in Bawnmore, where we had a behavioural team, and I was co-opted onto the behavioural team because I was working with individuals who were engaging in behaviours that challenge. I then, like Adele mentioned earlier on, I went down to Cork to hone my skills, and I studied in Cork University and did behaviour therapy. That was 1992, and I joined the behaviour team again then as a behaviour therapist. And in 2000, I became a clinical nurse specialist in behaviours that challenge. And in 2017, I became an advanced nurse practitioner with the Brothers Charity here in Galway. And at that time, there were only 2 ANPs in the intellectual disability field in Ireland.
Right, right. My goodness. So as with other practitioners that we've spoken to, you know, you're very trained. All of these people have really built on their basic nursing training to go on and to specialise as you've done. You mentioned, Maurice, positive behavioural support. Can you talk a little bit about this and just explain what it means?
Yeah, I suppose if you go back again to when I trained as a behaviour therapist, we were using behaviourist theory at the time, and the theory is fine, but really what we weren't looking at was looking at the whole person, I suppose. We were looking at their behaviours in isolation and trying to change people's behaviour, I suppose is the best way to describe it. And if you ask the group of people listening today, have they ever tried to change somebody's behaviour or change a partner's behaviour, and including yourself, Grania?
Indeed.
I think the answer for a lot of us is probably we've tried.
We tried and failed.
Yeah. So then we began to look at the process and said to ourselves, well, you know, the model here in terms of positive behaviour support encompasses 3 kind of core concepts. Values, theory, and process. Now, I'm not going to go into them too much, but just to say that the values piece looks at the dignity in the individual, including that individual, and treating that individual as an equal in terms of, you know, how we are going to progress their quality of life. So I'll just ask, Tom has a slide, number 1, that kind of simplifies the model for me. In looking at any individual, and all of us listening today, if physiologically we're not well, then expect behaviors that are going to be different from the norm. So if somebody has an earache, headache, toothache, back pain, whatever it may be, if we don't address that issue first, then you can use all the behavioral strategies you want and you won't change that person's behavior. The whole concept of this MASS model, and MASS been, and I like the Felican and Adele's use of the Gaeilge, we use it as well. The MASS model, MASS is respect in Irish. And really, in order to kind of get the sense of this, we build a foundation underneath which we try to look at a person's behavior. That foundation, like any foundation, is the starting place of a house. So if the person is not physiologically well, we need to address that. If the person hasn't got a good communication strategy, is not able to get their message across, expect that they're going to try to get their message across in a different way. And an awful lot of people that I support try to get their message across by using behaviors that we call challenging, but they could be very functional for that person. So they may engage in a particular behavior to get a message across to me that there's something missing in their life. Okay. The who is hugely important as well. If we have good staff who understand what they're doing, and building on Adele's one there should be an Adele in every county, we should have really good staff working at that core level with people who understand that whole concept of positive behavioral support, and that they embed it into their language, how they treat people, how they speak about them, how they manage everything about that person's life. Then we look at the environment and we ask, well, you know, if I was living in this environment, how would I feel? And if you go back to when I started in 1985, there was 33 men living on a unit in a service that I worked in, and the behaviors were huge. Nowadays, we have houses where we might support individuals, maybe 3 to 4 individuals in a house, and it's a massive difference to people. So when people engaged in behaviors of challenge in 1985, they were perfectly right, because what they were saying was, this isn't right for me. I don't like living with 33 people. And then communication-wise, you need to be able to get your message across. I work across the Gaeltacht community here in Connemara as well. And we have individuals in that community whose Irish is their first language. And we've one particular individual who gets particularly stressed at times. And if you communicate to him in Irish, he
The stress
begins to
levels drop.
de-escalate much quicker.
That's interesting.
So that foundation is massively important. And I would say to, again, asking the people that are listening today, there are individuals listening to us who would probably have or suffer from misophonia. And misophonia is that intolerance that you have for the sound that other people make while they're eating. Could you imagine living with somebody who made that kind of sound 7 days a week, 365 days of the year? A lot of us would try and escape from that situation. And that's one of the functions of behavior, is to escape from something that you find very upsetting. My role then, I suppose, would be looking at behavior management and introducing pro and reactive strategies. What are the things that we can do first that will actually prevent the behavior occurring in the first place? And then if the behavior does occur, how do we react to that, and what does that reaction look like? And I would say the more proactive strategies you have in terms of behavior, the better your strategy is. More proactive, less reactive. Reactive is a kind of a last resort strategy.
Right.
And then we begin to ask a person, well, let's look at giving you extra skills now so that you don't have to use your behaviors to get your message across. And you'll find that people's behavior changes automatically. And I just asked Tom to throw up slide number 2 to illustrate that point. When we ask people to change their behavior might be perfectly right for them. The thing that we have to do, and particularly for individuals with an intellectual disability, is we have to ask ourselves, okay, what's it like walking in your shoes? Can I take a walk over and see what life is like from your perspective? And then I might actually understand it better. And that's my role as an advanced nurse practitioner, is to do all those things that you saw on the original slide, but also to convince people. And I work across, I deliver training to older person services, intellectual disability, and into areas of mental health. And what we're asking the staff to do is take that imaginative step across and ask yourself, who has the capacity to change here first? And in all our cases, if we change our approach to that person, their behavior is going to change anyway. If my goal is to make that person's behavior change without changing mine, I'm going to fail. And that's like I suppose my time when I was a younger man, I would have spent trying to change people's behavior. What I really should have done was apologize to them for not having these type of approaches now, because we were starting from the wrong. We hadn't a foundation, we hadn't got the walls, and we were trying to put a roof on a problem.
Well, so, big changes in approach then,
massive, absolutely huge. And very much around respect and valuing people's human rights.
Yeah. And what kind of outcomes are you seeing from this, as I would see it, nearly a 360 change in approach?
I describe kind of changing organization as trying to turn a big ship. It's easy to turn a small boat. It's much harder to turn a big ship. But when you turn that big ship, the changes are huge. So you're absolutely right. For me, my caseload would probably have, is 80 individuals, but I operate a traffic lighted system of red, amber, green. When I started out first, I would normally have up to 20, 25 individuals in the red zone, which meant immediate kind of input from me at a very acute level. Yeah. I have 6 individuals in my red zone at the minute, and that kind of fluctuates between 3 or 4, which means that ship has turned, and the Brothers of Charity are particularly good at this in terms of embedding that positive behavior support into all our systems. I lost my train of thought. Yeah. So we've 6 individuals on the red list, and Tom is just going to throw up a slide number 3, which kind of illustrates how a person can change over a particular period of time. So this gentleman here had 118 incidences of behavior as a challenge, kind of serious at the time, and resulted in a lot of difficulties for us to manage that situation. Over the number of years, by changing that ship and by turning things around and embedding that whole process in our system, he had 1 incident so far this year, which means that literally he's down in my green list. He's gone off it. But what it also tells us there, Grania, is had we got things right originally, I would never have seen that spike of 118.
No.
What's important for us now to remember is that if we take our eye off the ball and take that scaffolding out from underneath him, you can take that graph and just turn it over and you'll see things beginning to rise up again. So we really need to be consistent in our approach as well.
Yeah. So the kind of feedback, I mean, that's it. Look, this chap, I mean, that speaks for itself, that histogram of different. So what are the patients and their families saying to you? I'm particularly mindful of that chap now and his family. I mean, the worry and concern of those behaviours he'd been having all those years ago, and now they're seeing him calmer, quieter, better in the world. You know, it's extraordinary.
We have the enviable position in our organisation of having a human rights committee with external members on it, including the members from the Law Society in NUIG. Now, that individual's father came to our Human Rights Committee along with his son to speak up on our approaches in relation to possible restrictive practices in his life. And he said at the meeting, which I was very chuffed by, and he said, "This is the happiest my son has ever been." And he said, "And by such, it's the happiest we've ever been." Yeah. So it was a lovely feeling for us. But more importantly, what it says is the positive behaviour support has worked for that young man, because positive behaviour support is supposed to be a prescription for quality of life.
Yeah.
Okay. So if we write that prescription, it has to be followed. And if it isn't followed, then his quality of life suffers on account of that. So that's really, I suppose, my role as an advanced nurse practitioner is to be a practice leader in that kind of area. So that was Dad's words, and that's across the board. We're getting great feedback from families. Now, trust me, Grania, they don't all turn out with a 98%.
Sure.
There are some I'm still working on. Sure. But in the main, the Brothers of Charity, myself included, along with our team, we're good at this, and it means that people's quality of life has improved hugely.
Yeah, definitely. So what's next, Maurice, for this type of intervention? Is there a potential to replicate this?
The lovely thing about this is that, and I was chatting to Liz Breslin this morning, and we were just talking about the number of advanced nurse practitioners and candidates in the intellectual disability field. While there was 2 of us back originally, there are now 7 full ANPs within the intellectual disability services and 15 candidates across the board. So a bit like what Brian and Owen were saying, if you can get 1 in every county, imagine the quality of life changes for all those individuals. So I'm delighted, and we have a forum where all those AMPs and ID and candidates meet, and we discuss how we can support each other through this.
Great. Look, Maurice, that's super. Thank you so much for describing that exciting service, and what I can see immediately, the obvious impact. And I just love that idea of, you know, you moving into this service and seeing, you know, something needs to change here, and let's look at that idea of looking at the physical environment. I mean, you know, you often think, you hear things that have happened to people and they do awful things, and you think, actually, that's the correct response. You know, if X happened, the correct response is to run out in the street screaming, but it's not an acceptable response often. So look, well done. That's a super program. And I know you're going to stay there in the background, and we'll call you back in, I think, when we get to the panel. I'm sure there'll be comments on the service. Thank you so much.
Thank you, Brian.
Again, another super advanced nurse practitioner applying their work in a very interesting role. The next person I spoke to, again, advanced midwife practitioner in diabetes, Ciara Kovney. Ciara is from the National Maternity Hospital. Let's hear from Ciara now. So I'm delighted to be joined this afternoon by Ciara Kovney. And Ciara is an advanced midwife practitioner at the National Maternity Hospital. Ciara, you're very welcome. Thank you so much for joining us.
Thanks a million for having us, Corona, today.
So Ciara, you are, as I say, an advanced midwife practitioner in the area of diabetes in pregnancy. Can you start though by telling me your journey, how you became an advanced midwife practitioner?
Yeah, of course. So I trained as a general nurse in Tala University Hospital, AMNCH as it was back in my day. And I came to the National Maternity Hospital straight after qualifying, actually, in 2009. And I worked here for a while in gynae services, and then went to do midwifery in UCD and here in the National Maternity Hospital. And I worked in all the core areas of midwifery practice, and realized probably from the time I started my general training that advanced practice was something that I absolutely wanted to do. And then started to see opportunity of where I could advance to working in an advanced practice role. And for a while I worked in bereavement services here in the National Maternity Hospital, which was wonderful. And then I moved across to diabetes and pregnancy. And in order to register as an advanced practitioner, you obviously have to fulfill competencies and an academic element as well. So I went and hired a postgraduate diploma in diabetes care, and then a master's in advanced practice and prescribing in UCD. And that was quite a long academic road, because you had to have nursing, midwifery, diabetes, and the master's then. But once they were all undertaken and you had the relevant clinical experience, I was finally able to get a candidacy position and then register. So I'm registered 2 years now.
My goodness, so it is a long and sounds to be quite a challenging road to get to where you are. So just talk a little bit about, what is the role of an advanced midwife practitioner? You've got all the training under your belt and lots of experience now. So what is the step up, if you like?
So as distinct from, say, staff midwife or clinical midwife specialist, an advanced midwife practitioner utilizes advanced decision-making skills. So you have your own defined caseload of women or of patients, and they're defined in conjunction with, say, your director of midwifery and a mentee or a supervisor. So in my case, consultant obstetricians and consultant endocrinologists. So you have a defined caseload of patients that you are clinically responsible for, and you utilize the skills that you've gotten through experience and through your academic training for advanced health assessment, diagnostics, interpreting diagnostic and laboratory results, decision-making skills. So you're able to diagnose, assess, implement a treatment plan, and you're also able to admit and discharge. So often what I will find is I have a fantastic midwifery team that we support here, and there's 2 other midwives working with me, and they often will escalate patients up to me if they feel that they have gone beyond their scope of practice. And the same with me, I can escalate to consultants. So it's that higher level decision making and ability to look at complex medical situations and be able to make an assessment on that and be able to diagnose and treat appropriately.
Right, that's really clear. Thank you so much. And then talk to me just a little bit before we go into the detail of the fascinating work that you're doing with the gestational diabetes patients. Just tell me a little bit about the difference between consultant-led versus registered advanced midwife practitioner-led care.
I think there's kind of probably 2 prongs to that. I think if you look just at the roles in themselves, they're obviously very distinct and separate professions, but there's a great interdisciplinary sense that these disciplines come and work together very well. So I think from midwifery and nursing and our medical colleagues, we come at things from very different training, very different outlook, and are able to add different elements to care, if you will. I think it's nice for women and service users to be able to meet people with different, we can all bring something to the role.
Yeah.
For consultant-led care, in my area in diabetes and pregnancy, we have obviously the women that are there are high-risk pregnancies. They're at the very top of that maternity strategy. They're in the specialist care pathway. And I like to feel like with advanced practice and consultant-led care, it complements each other. So my cohort of patients that I would be exclusively responsible for are women with gestational diabetes. And then I would conjointly care for women with pre-existing diabetes, like type 1 or type 2 diabetes, in conjunction with medical colleagues, with consultant colleagues. So consultant colleagues certainly would look after the more complex medical issues at the top of that high-risk pyramid. But that's the big difference, I suppose, is in the complexity of care and the complexity of the decisions to be made.
Okay, so really they're complementary rather than one versus the other, as you described them. So look, take me into this really interesting initiative that yourself and your colleagues have developed, whereby really working in the National Maternity Hospital, you've eliminated the need for gestational diabetes patients to come to the hospital, which of course, as we know, is a great Sláintecare ambition to reduce footfall. So talk a little bit about how you've done that and the impact it's having.
Yeah, we were really passionate about being able to deliver care closer to people's homes and to be able for women to access care in the Sláintecare kind of motto of at the right time with the right people and be able to see the right professional in a really timely manner. So we looked at what we were doing, and COVID played a part in it, but really it was something that we did want to do anyway. So it kind of expedited the process, if you will. And it let us look at, was what we were doing working? And was it serving the people that it really needed to serve, putting the person in the center of it? So putting women in the center. And we looked and saw how we could do better. So what we do is we don't bring women into the hospital at all. They have online education sessions, and then they're able to have a virtual review with a member of a specialist midwifery team. And we use a lot of digital technologies, a lot of digital health technology to make that journey easier for women. So they have, for example, glucometers that hook up to their smartphone that communicate all the data back into the hospital. So it allows us to have everything to hand to be able to provide a very comprehensive assessment when we see the person, but also kind of having a blended hybrid approach, knowing that sometimes it may not be suitable for everybody, but it's really nice to see people, because I think when we first did it, we were doing it by telephone. And actually, even seeing you now, Grania, you're able to see the person, you see the expression on somebody's face, you know, you kind of, I think there's so much more in body language and seeing somebody. So essentially from the time of diagnosis through to discharge for gestational diabetes, if a woman stays on diet and exercise therapy, they are cared for exclusively by the midwifery team, and they do not have to attend the hospital for any of their diabetes care.
Right.
So for our cohort, we have about 800 women a year, and about 75% of those women are managed at home.
Wow, isn't that great? And I guess then, you know, the impact of that on, you know, your virtual work, reducing the footfall for hospital attendants, leaving the spaces for people who really need to be in, appearing, and getting that kind of, you know, not just face-to-face, but hands-on care that some other patients might have. Tell me a little bit about, I mean, obviously this was developed during COVID, not necessarily as a response to it, but certainly during it. How have you measured your outcomes, and what kind of outcomes do you think you're getting?
So we've just finished data analysis actually on a study that was funded by the NMTDU. So it's a midwifery-led study, and it's looking at our maternal and neonatal outcomes. So it's looking at what happened when people were in person and they saw a consultant, and it was a consultant-led service. And now what happens when they're virtually managed by an advanced practice-led service. And we have some very initial results back actually only last week, and we found that the access to care was much faster. 90% of people were treated within 10 days, 70% of people treated within 5 days of diagnosis, which we were really delighted with. We found that the amount of babies that were admitted or required any time away from their mum in the neonatal intensive care unit also had dropped.
Wow.
And it had reached statistical significance. We were really happy with that. But I think one of the more comforting things for me as an advanced practitioner, and obviously my medical mentor, Professor Tunik, trained me. So, you know, I wanted to make sure that my decision-making wasn't wildly different from his. You know, the decision-making had to be sound, it had to be evidence-based. And actually, when we look at the amount of women that are on treatment, and we look at delivery outcomes, and we look at maternal morbidity, those things are quite similar. And I think for me, that was quite reassuring to know
consistency.
Absolutely. Consistency is key to deliver those outcomes.
Very good. Very good. That's great. And great that you have that to share with us today. And from the women themselves and their families, what are you hearing from them?
Women are really delighted with it, especially women who have gone through 2 iterations of the service. So the women who have had we had a traditional breakfast club where they had to have breakfast in the hospital in a very small confined space. And most people found that very uncomfortable. And they were in a minimum of every 4 weeks, maybe 2 to 3 weekly. Now it's a 5 to 10 minute video consultation. People can come in if they need to, but they more often than not don't. And I mostly will do reviews with women with their children sitting beside them, dying to see who's on the screen. So there's no requirement for childcare. There's no requirement for transport into the hospital. If a person's in work, they'll often just ask for 10 minutes to step outside and take the call. So it's not requiring time off work. It's not requiring trips in and half days into a hospital. So the feedback is incredibly positive. And we also wanted to make sure that it reached demographics of people traditionally who've been more difficult to reach, and maybe our colleagues who would require an interpretive service, for
Right.
example. And actually we find it really, really helpful for that, because at a time where we're finding it difficult to maybe have interpretive services, to ask them to be present for a 10-minute video consultation is a lot easier than coming into a hospital.
Very
so not
good.
only are the majority of people saying they're finding it really easy to access, but the people we really made sure we wanted to reach are finding it easy to access as well.
That's fantastic. And finally, Ciara, are there other areas that you feel this role of advanced midwife practitioner could have an impact and maybe contribute to the wider reforms of health service delivery?
Absolutely. I think I feel really passionately that advanced practice can have a huge impact at a national level. I think it's really important that as a clinical voice and as a person who is clinically looking after people, that midwifery is represented at national and international level, that we have a say in the development of clinical programs, that we have a say in the development of pathways of care for people. We are so well positioned, and we can act as advocates for women and their babies to try and advocate for the best outcomes that we can, and to hear from women that are using services and say exactly what they like. We can see, I see one of my colleagues is working in postnatal, and that transition into parenthood, and that has proved so important, and it's such a valuable service for women. And then if you look at, say, evolving public health concerns, so we have the upward trend in obesity internationally. There's such scope for advanced practice to be able to innovate and change care for not only population health, but for the people they're immediately caring for.
Brilliant. Ciara, thank you so much. Well done on the work. It's really exciting. And thank you very much for joining us this afternoon and telling us all about that. Thank you very much.
Thank you, Grania.
Well, great to see the satisfaction and outcomes for Ciara's patients and the positive impact of that virtual service. Again, I think demonstrating the value of providing care where possible outside of the hospital, and really so much benefiting the access of to the service of women without having to traipse into areas of acute hospitals, which may not suit them at all. So we've been getting great feedback on the chat line from the programme so far. We're now going to turn to our panel discussion, and I'm delighted to ask Kelly Mofflin to rejoin us, Deputy Chief Nursing Officer in the Department of Health. I'd also like to welcome Dr. Geraldine Shaw, Nursing and Midwifery Services Director. I want to welcome Paul Gallagher, the Chief Director of Nursing and Midwifery at Ireland East Hospital Group. And Paul is also Chair of the Chief Directors of Nursing and Midwifery. Finally, we are delighted to also have Emer Hearn, Consultant Trauma and Orthogeriatrician in Cork University Hospital and National Clinical Advisor and Group Lead for Older Persons. I'd also like to call back in Maurice, if I might. Maurice, we've had a tsunami of response to your piece, and we have some questions to put to you. And just before we do that, I also have some lovely comments or Adele, not questions, but comments, just saying to Adele and the Felican project, Deirdre and Teresa saying, just super to hear about that project and the work that Adele is doing, and people particularly wanting to pass on their good regards to Brian and Una, the importance of hearing the patient voice being really well appreciated by those who are attending the webinar today. So I'm going to come back to you first, Maurice, if I might. Some of the questions coming in on our conversation. One is about just a question of what age group do you deal with? And then a question about the level of severity to enter your program. Have you a benchmark, or a too high for us or too low for us? Is there a benchmark? And then a question which I think is an interesting one about so many people are at home with members of their family, having, ID or behavioural issues with no supports. Your advice on how to manage this or access the approach you are recommending, and help people to help themselves to manage their own behaviour. And then finally, just a comment on safeguarding. In your view, is the safeguarding working, and are people in the services, are they safe? Big question. So deal with them as you can. Thanks, Maurice.
To answer the first one, I think it was from Pauline. I was supposed to be adults only, Pauline, and then I got drawn into the school system to support individuals. I suppose I heard a lovely comment during the week. Today's favour is tomorrow's expectation, and you go down, you do a favour, and it works. And again, it's part of that team process. So I'm in the school systems. I go out to primary, secondary schools where they would have a connection with us, and I would deliver training maybe to the staff pre the new semester in school. Last week and on the 17th of January, I think I'm delivering a course to preschools in East Galway, and I delivered a course to Nenera in Connemara as well just a couple of weeks ago. So to answer that question, it's across all age groups, because the level of behaviour that you see, you can't operate a wait list. I don't operate a wait list. It's immediate. To go out and see, can we get the ball rolling, because people need support immediately.
Right.
Avril Duignan, I think, asked about family support. Again, that's something we do as part of the organisation. When COVID hit, I found myself sitting in people's front gardens trying to support them, because you had adult children back home with families as services closed down. Yes. But also we do that as a matter of course within the organisation. And I think one of the things that I'll be discussing with Liz Breslin and people like Judy Ryan after today is, how do we ensure that the other ANPs and the other candidates bring this type of support across the country where they are operating? And that's part of that kind of forum that we've set up, where we'll help each other and maybe say, look, here's what I did in that forum. Yeah. The safeguarding piece, Safeguarding Ireland have great documentation, and in there they're looking at the freedom principles, fairness, respect, autonomy, dignity and equality, which is what I mentioned earlier on. For us, operating our Human Rights Committee is very much part of that. But it's only as good as the people on the ground, and if we can train them to be mindful of the types of abuse that are out there, because it's not all physical, verbal, there's other types of abuse that people may be subjected to. But to open your eyes, in the 90s, McIntyre Undercover exposed abuses in the intellectual disability services, and we thought that would be it. And then we had Winterbourne View, we had Bungalow 13, we had Wharton Hall in 2019, and then we had other abuses, financial, across services in 2022. So it's down to the people listening to this today to open our eyes, open our ears, listen to what people are saying, respect individuals. And one of the things we'd say when we're training is, if you treat the person that you're working with right now as if they were your brother, sister, cousin, aunt, uncle, mother, father, you generally won't go too far wrong. But treat everybody else as the same as well, and keep your eyes open, because there are little spanners in the works that we need to weed out, I suppose. Yeah,
super. Thanks so much, Maurice. Can I move to over to the panel now, in terms of maybe back to Kelly, first of all, around the role of the Department of Health is to provide strategic leadership for the health service. As Deputy Chief Nursing Officer in the Department of Health, what is the Department of Health's strategic direction for advanced nursing and midwifery practitioners? You touched on this a little in your opening comments, but where are we going briefly? Thank you.
Thanks, Grania. So absolutely, the department's policy direction for advanced nurse and midwifery practitioners is really to try and continue building and developing that critical mass of advanced practitioners in line with Sláintecare. And we've heard from our 3 advanced practitioners there, and some of our patients and service users and people that are using the services, that we want one in every county and access to them everywhere. So really that's one of our key things, is trying to continue building that critical mass of advanced practitioners that aligns with Sláintecare and other national health strategies, and that are providing services that don't rely solely on hospital-based systems. So we've heard there from Kira about how, I think I took a note there, she said something about, I think it was 75% of women that she's working with, she's able to provide services outside of the hospital, and the difference that makes to people that can access that service. And I suppose the target for us at the moment, the current target for, I suppose, the number of, or the percentage that we'd like to see advanced practitioners at, is 3% of the nursing and midwifery workforce.
Right.
So that's kind of one of the key pieces. I suppose the second piece is that we're also trying to look at how we strategically continue to implement and develop advanced nursing and practitioner and midwifery practice. So that'll involve an evaluation of the current policy and the impacts and what we've seen and what's worked and what's not. So that'll be a piece of work for next year. And that ties in obviously then with one of the 47 recommendations of the expert review body, is to review that policy as well. So that's some of the snippets of the key kind of strategic priorities for us.
Yeah. So sounds like it's really moving ahead there. Could I come to Geraldine? Geraldine, you're very welcome this afternoon. As Nursing and Midwifery Services Director in the HSE, can you tell us how advanced nursing and midwifery practitioners, how they're contributing to the priorities of the HSE in your view?
Yeah, thank you, Grania, and very happy to do that. And I am a big advocate of ANPs within the system. So Kelly has outlined some things there from the Department of Health perspective, so I won't repeat what's already said. But I think it's important for the audience to know that we do work in tandem with the Department of Health around priorities in the first instance for advanced nurse and midwife practitioners within the system. So just to kind of recap for the audience in terms of 2022 with additional funding that came into the system. So the Department of Health and the HSE agreed the priorities in the first instance for these posts. So again, just in brief to recap, Kelly has already mentioned, but it is about building a critical mass of ANPs across care areas where patients are impacted by waiting lists and delayed access to care, delivery of care in the community in line with the Enhanced Community Care Programme, including use of community virtual wards, expanding the management of chronic disease, delivery of advanced care in unscheduled care settings, maximising hospital admittance, also utilising advanced nurse and midwife practitioners in the implementation of what are national strategies, and as colleagues will know, they range across the whole gambit from women and maternity services right through to intellectual disabilities, mental health, etc., and all in between. And also in 2022 as well, priority listing was the responding to the COVID-19 situation as well. So just then, whilst, in 2023, there may be some changes to that, which we can certainly predict that some of the core elements or priorities will remain around impacting waiting lists and delayed access to care, delayed, delivery of care in the community in line with Sláintecare, the Enhanced Community Care Programme, and also utilisation of the virtual ward concept and model, but also advanced care in the unscheduled care areas and settings and maximising hospital avoidance. Across the system, in terms of advanced nurse and midwife practitioners, we can see at the moment that ANPs are impacting a whole range of services. Those areas that I've mentioned that were perceived as priorities by the HSE and DOH in 2022, but also across a whole gambit of areas, as has been outlined by our presenters. And to me, a key contribution of the advanced nurse and midwife practitioner role is that higher decision making, that higher scope in terms of managing a whole episode of a patient care. And this is really important to the HSE in terms of delivering priorities, hence the significant impact that ANPs are having across the system. So for sure, they're really supported within the HSE services, and particularly over the last two and a half years with COVID, we have seen how advanced nurse and midwife practitioners can respond to rapid change within the system. They can adapt new ways of working, as you've heard by some of the presenters here already today. And, that whole adoption and progression of the e-health and digital technologies, which is so significant in the 21st centuries. So again, as you've heard from Adele and Maurice and Carey today, prime examples of what's happening in the system, just touching the surface. And certainly we'd all be advocates of having an Adele, Maurice and Carey across the system in every county at the very least. So in summary, they make a significant contribution, not just a contribution, but a significant contribution to the system.
Yeah, that's great, Geraldine. Thank you. And I think the point you make about the ability to do the step up, we're seeing that. We saw it in other webinars, people in cardiology, diabetes care, other chronic conditions, the role of ANPs really being able to step up in terms of the care, make decisions in that enhanced care, and so important across so many different fields. Again, there's a lot of A lot of activity on our chat today. People saying excellent work, Kira, and Kira might come in. I think we have a question for her. People loving the blended approach, saying this is the way forward. Great to have an ANP in the area of midwife. What a great service. Kathleen is saying fantastic presentations by all the speakers. Thanks, Kathleen. Great to hear so many successes in advanced practice. Question for Adele, if she's there, if she can come in. From Deirdre. Deirdre is wondering, Adele, we spoke a little bit about the future, but she wonders, are there actual plans to scale up your service? Brian is wondering, plans to scale it up?
Hi, Grania. Yes, there's plans to scale up. The project management office in CHO7 are working to support me to map out the pathways and to see what's needed. There will be more staff coming on board with me, and then the plan is to go back to the National Dementia Office and sit down with them, with the Nursing and Midwifery Practice Development Department, about replicating it nationally.
Brilliant. That's great. Thanks, Adele. Paul, may I come to you? You're very welcome to the panel this afternoon. As Chief Director of Nursing and Midwifery for the Ireland East Hospital Group, what are the benefits for patients that you and your colleagues are seeing in our hospitals from this role of the advanced nurse and midwifery practitioner?
Sure. Thanks very much, Grania, and thanks for having me this afternoon. You started off the proceedings this evening by talking about the right care, the right place, the right time by the right people. And that really, they're the benefits as I see it. I think of my experience in I was Director of Nursing at St. James's for 12 years before I came into this role 4 years ago. And I suppose I can see firsthand in the acute setting, the absolute acute, in the acute setting, the benefits. And you see where advanced practice is embedded within a system, especially in the acute hospital setting. The foundation stones are laid very, very quickly with like-minded people, like Adele, Maurice, Kira, all were well-positioned, well-supported within their own organizations. And I suppose really what you see then is the impact on patients, I suppose the whole thing around having a very strong partnership at local level. I think governance is absolutely key, and strengthen governance. And I'm going to touch on that word maybe as often as I can. The whole thing around having a supportive structure for education and training to allow nurses and midwives progress on that career trajectory for advanced practice. And then there's the whole thing about, there are other really important aspects of the role. And Kira hit the nail on the head about her research. I mean, this is amazing work, very practical, very patient focused, but really, really beneficial. But I suppose in summary about, if you're to summarize the benefits, really just listen to what Brian and Una had to say. They have firsthand experience. They're telling us about they're receiving the right care, the right place, the right time by the right person and the right team. And I think that's whatever I have to say is like what Brian and Una's experience really says it all.
Okay, that's great. And Paul, around, I mean, obviously integrated care is such a huge direction driver, such an important area for reform right across the system. The relationship between advanced practice and integrated care, do you think there's a link there in terms of one being very important to deliver the other?
Yeah, when I was considering all of this for today, you have a situation where advanced practice and integrated care is about really having the care provided to the patients near their home, or as near to their home as possible. And there have been a number of initiatives that have been referred to, I suppose, or have been that have taken place. And a lot of it is around, service in the right place at the right time. And the allocation that our colleagues in the Department of Health have given us for funding for advanced practice has been fundamentally important. And as Kelly rightly said, trying to achieve a critical mass of 3%. And the big focus over the last couple of years in that regard is how funding is going to provide advanced practice in an integrated setting. And, there's a lot of, I suppose, data out there around, well, what are the drivers that really require advanced practice support to support integrated care? So there have been the big issues around how posts have been allocated. I think the big issue is really trying to avoid, from an acute hospital perspective, it would be remiss of me not to mention it's about, avoiding unnecessary admissions to hospital. It's about trying to get people in an advanced practice role to educate, train, not just patients and service users, but staff out there in the community, to enable them to avoid, sure, look at call the ambulance and we'll just move Joe Bloggs into the emergency department and they'll be gone for a day or two or longer. So, you know, it's about, you know, and I think Kira, and I know Kira well, she's working in one of our 12 hospitals in the National Maternity Hospital. It's about how advanced practitioners can influence care, influence the pathways of care, and making sure that patients are not going to be just popped into an ambulance, but that everything is going to be done for them as near to home as possible. And so I think the contribution of advanced practitioners and indeed senior nursing midwifery leadership around having appropriate pathways of care and integrated pathways of care is going to be essential. And, you know, you think about the principles of Sláintecare, and, you know, the patient is paramount. That's the role of the advanced practitioner. There's timely access to a service. It's not an acute service, but it's the right service in the right place. There's another principle about, you know, preventative care, that the patient and the service users are, you know, taught how to help themselves. Then there's the other bit about, you know, workforce planning as a principle of Sláintecare, and, you know, having appropriate, accountable people who are well resourced. So, you know, I think it ties in very, very well, but I think what really will pull it all together as this evolves is really strong, robust governance.
Yeah. Okay, great. I'm going to come back to the issue about ambulance service. We have a really interesting comment in. I'd like the whole panel to comment on it. But before I do that, I'd like to go to our other panelist, Dr. Emer Ahern. Emer, you're very welcome. Thank you for joining us this afternoon. Emer, as a consultant, what benefits are you seeing of advanced nurse practitioners?
Well, I think I probably couldn't articulate it as well as Adele and Maurice and Kira have done, actually. I suppose I would see, you know, advanced nurse practice. I suppose one, I think, again, our panel, you know, the speakers today really have spoken to the value to patients and the outcome for patients. That's been absolutely clear. And I think when we talk about Sláintecare and the principles of Sláintecare and integrated care, I suppose for me that would mean that patients, when they enter into the system at whatever point they enter, whether it be with their in primary care in the acute hospital, that they will receive kind of continuous coordinated care. And I certainly think advanced nurse practice is kind of fundamental, kind of an enabler of that, to be honest. So I see that would be a kind of a key part of their role. But I do think that there has been, I think actually advanced nurse practice is enhancing healthcare in general over and beyond kind of, you know, that. And I think there has been a ripple effect from advanced nurse practice recruitment into healthcare in Ireland. And that I think in addition to allowing kind of nursing kind of career progression and increasing their scope of practice, I think it actually is allowing all members of the health service to operate at their peak of their practice.
Yeah.
Actually, by doing that, I think it actually is it's kind of raising the whole workforce by kind of being part of that team. So everyone is actually allowed to do that. So I think that is probably something that's not really as tangible, but I think is definitely kind of happening within the system when you see that. And I think by allowing people, so, you know, we're increasing the access to specialist care. So medicine is getting more and more complex, it's getting more and more specialist. So this is absolutely, again, kind of another kind of dimension that we've brought in to improve the access to specialist care. And then, you know, at an organization and healthcare level, you know, I mean, everybody, you know, every kind of professional in healthcare will say that they're, you know, faced with recruitment challenges, and you know, it's not only healthcare, you know, we're seeing it everywhere, you know, but I do think this diversification of the workforce, you know, is just absolutely critical, not only kind of just to get more and more people in, but I think it actually kind of strengthens the healthcare that we do provide. And in order to kind of improve the quality of care that we're doing, and to get the perspective of all the different professions who we're working with, I think that diversification into specialism is really, again, fundamental actually to getting it right for the patients who kind of need our services.
And Emer, maybe would you speak a little bit about working with older people? You know, it seems to me from some of the people we've spoken to in previous programs who are working around, whether it's integrated care for older people or working in services for older people, the ANP and the needs of older people, there does seem to be a good fit there, doesn't there?
Oh no, absolutely. And again, I think it's about kind of like, I suppose, older adults, as we see, as they get kind of, you know, we're all kind of aware of the Department of Health report that was published last week with increasing numbers of older people, but then with that proportion that have complex health and social care needs. So they will always be in need of this kind of continuous coordinated care. It won't be episodic. And I suppose we can see harm when they do get episodic care. So I think there's been huge kind of recruitment into advanced nurse practice, especially in the area of older people, kind of from Adele and what she's doing into frailty, into falls. You know, there's so many like subspecialty, stroke, trauma within it. And I think it's really kind of like at that point, and I think, Brian and, they really spoke to that, kind of their experience of it. And I think kind of older adults and kind of the care of older adults and that level of complexity is really very much kind of attuned and attends to kind of advanced nurse practice and the scope of what people can do kind of within that. And certainly we're seeing just kind of like, we're measuring the outcomes. So the outcomes, have been just huge really in terms of the quality of care and just and again, kind of the value of the care, not only to the patient, but also to the system. So this is, better care, kind of better quality care actually costs less.
Yeah. Great. So a comment has come in from Robert Morton, and Robert says, the National Ambulance Service would like to introduce ANPs into our alternative care pathways portfolio. For example, minor injuries, respiratory care. The National Ambulance Service is not a traditional work environment for nursing, but we are developing a coherent nursing governance structure to support our nurses working in our evolving clinical hubs and our critical care and retrieval service. What's the panel's view on that? Paul, maybe back to you first.
Yeah, I'm happy to start it anyway. Sorry, I just kind of tried to log into emails there because there's a newly appointed director of nursing working with the National Ambulance Service, Anne. I'm sorry, I can't remember Anne's surname, but I think it would be a fantastic opportunity for the likes of myself, Ger, Kelly, to meet with her to go through the requirements of the service. And I suppose I'd just like to separate out, we've got advanced practice, which is essential. But it's not just about advanced practitioners. There are clinical nurse specialists who could be on that trajectory or that journey. But I think that the question is a very valid question, and but I think it'd be really worth exploring with Anne as the newly appointed director to share with her our experience. And Kelly, you've got and Gerald will be aware of the allocation that comes out through the Department of Health and through the ONMSD for funding. And it's all about everybody being positioned in the right place at the right time, as in having your correct business case. So there's a lot of opportunity, but perhaps my lived experience in trying to get funding over the last few years for advanced practice. But I think it'd be a great opportunity to link in with Anne and the ambulance service itself. I don't know if Kelly and Gerald.
Yeah, no, I'd support that as well. Yeah,
Kelly,
Paul. Yep. So no, I agree. I suppose in terms of that building the critical mass, I suppose it is an incremental process. So obviously there's a certain amount of allocation of posts each year that we started with this year, around 149, and we are going to be allocating more posts next year. We haven't got the full amount as yet, but it's certainly an area that we could meet and look and consider and see what the benefits might be and where it might fit. There's never any guarantees where posts can go unless they align with strategic priorities. But certainly this is going to be an ongoing process of incrementally building critical masses. So it's certainly an area we could consider and look at in a bit more detail.
Thanks, Kelly. Ger?
Yeah, and just to say that, Paul, it's Anne McCabe is the person's name. Yeah.
Well done.
Yeah. So, and Anne has, a strong background in nursing, but also knows a lot about the ambulance services as well and how they would link up. She's very experienced, been around the system quite a long time. But just in relation to the ambulance services, so even already between acutes particularly and ambulance services with retrieval of patients and with outreach and so forth, right? So there is already connections in terms of that advanced practice piece with ambulance services and acutes around different modes at the moment. But certainly, that is an area for sure, because as has already been said, it's about the right care in the right place, the right time by the right people, and utilising the full capacity of the workforce. So for sure, that is an area as well.
Emer, have you a view on this?
No, absolutely. I would kind of 100% kind of support this. I suppose I would think, again, it's about that kind of each kind of aspect of the service enhancing kind of the roles and functions and practice of the other. And I know certainly kind of working as a geriatrician, kind of when the paramedics and kind of the reports that they would give in handover would be kind of the first thing that I would go to. So again, to have that the workforce area, it's already, the National Ambulance Service already developing pathways for older people with health and social care professionals. And I do think, again, it's that multi-dimensional kind of nature of kind of like that will, that especially older people need that advanced practice in that area would be, again, only kind of additive and synergistic kind of with the whole kind of terms of delivery of care.
Yeah, and another one, again, I'll come back to you all briefly on it. Is there a need to expand advanced practice within GP practices to increase service users' access and avoid possible hospital admission? Currently, EDs are overrun with patients that cannot access GP care. This is a common thread we're seeing coming up quite regularly. View on that? Is the answer just yes? Paul, would you want to come in on that one?
Look, I think anything that's going to avoid I suppose ensure the appropriate placement of a service user or patient was welcomed. I believe, and I don't have the exact detail on this, but I believe some GPs are starting to hire advanced practitioners. And I think what's going to be fundamentally important is, whilst yes, it's great to have an advanced practitioner within a practice, for the practice alone is fine, but it's the broader requirement for how that role, I suppose, works across the acute hospital community divide, we'll call it. And I think whilst then they're presumably going to be a private or a privately employed, but what is key is how that integration piece works. And I've mentioned governance, and I'll mention it again.
Yeah.
If it's going to work, there has to be a partnership approach as to how the role will be successful. And it's not just focused on the GP practice, but it's about how the GP uses their advanced practitioner to work across the boundaries. And there are many different examples around that. And I know we had an advanced practitioner in Navan, and she ended up to sell her wares, shall we say, from an acute hospital perspective, used to go and wait and sit in the queues in the GP's waiting rooms so that she could let them know what she was about and the services that she was going to provide.
Right.
Then it evolved into, she didn't need to phone the GPs, they phoned her. So they see the benefit of it. But I suppose it's how that person, whether they employ that person or not, but it's how that person works across the acute community divide, we'll call it.
Yeah. Geraldine, you're nodding at this one.
Yes, and just to say, look, there's a small nuance, what I mean, in this particular arena, and which, obviously is that the GPs are independent, private providers, and the staff recruited in GP practices are privately recruited, subject to the GP. So the small nuances in the bigger picture, in the sense that obviously we cannot take from that, from a point of view of HSE in the public service.
Sure.
Right? But that is, at the higher level, a piece in terms of HSE and department, right? Okay, in the funding and strategy around that, and those areas working together under whatever, be they SLAs or MOUs, etc., like that. So just putting that little piece on what Paul has already said.
Yeah, no, that's useful. And again, we won't have time to take them, but comments coming in about, the role of the nurse in rural, remote and isolated areas, including offshore islands, to be considered for development to advanced nurse practice roles. These nurses are often working within the context of expanded practice, providing healthcare within what they're calling underserved areas. And the last comment, Michelle is saying to us that in CH09 in Dublin North City and County, they're actively pursuing the need for an ANP in homeless services, and also the lack of access to medical care for international protection clients, migrant health ANP, for example. Huge potential for the service and the clients. Paul, do you want to come in briefly?
Yeah, just very briefly, that whole thing about inclusion health is so important.
Yeah.
And it's again, I worked in James's, and it's a really strong, robust model that's being developed, and it's been replicated elsewhere. So yes, it's a no-brainer really that advanced practice would be part of that. So it's a great opportunity.
Yeah, super. Thank you very much. I'm afraid we've come to the end of our time. It really does fly. I want to thank all of our panelists. Great session this afternoon. I want to particularly thank all our guests. I want to thank, in particular, Adele and Maurice and Ciara, not forgetting Brian and Una. I want to thank Rosaline Harlan. And I want to thank Sheila Cahalan, who really provided us with so many of the speakers and direction for where we might go today. And I hope you'll agree, it's been a very fruitful session afternoon. I also want to thank Tom Duke, who does our technical hitch fixing, of which we had 2 minutes before we came on air. So thank you, Tom. You can, of course, watch the webinar back or recommend it to your colleagues. It will be available on the Sláintecare website. Been really interesting topic. Thank you all so much for all the work that you do and for being the drivers of the change that we know we need so badly. As I say, it'll be up on the website. Thank you all for your time. And from me, Gráinne Healy, continue to stay safe, and can I wish you all a very happy Christmas. Thank you very much.
Thank you. Cheerio.
Thank you. Bye-bye.